So as we see that inflammation and infection are close to each other, but they are not always the same. There are many conditions that can cause inflammation without infection, and we need to identify them so that we do not use our antimicrobials unnecessarily and creating further antimicrobial resistance. The conditions which are notorious for causing inflammation are trauma, pregnancy, burns, and pancreatitis. Inflammation can also be seen in blood transfusion and hypersensitivity in certain patients, and inflammation may be absent in patients who are immunocompromised in presence of infection. So we need to screen patient for risk factor for immunocompromise like diabetic, transplant recipient, cancer patients, extremes of age, patients who are extreme obese and have multiple comorbidities, pregnant patients, they are particularly immunocompromised. Majority of the sepsis is caused by bacteria. Majority are bacteria and very minor are fungus, parasite, virus and other. Furthermore, majority of virus you can't do anything. We do not have any proven treatment for many viruses. Fungus mostly affects people with suppressed immune systems. Parasites as well affect people with suppressed immune system. So do not use fungus and parasite cover in every patient. If you don't understand anything, doesn't mean that you have to add a fungal cover. Sepsis is the diabetes of ICU. It is present in, like, you do not know what's going on with the patient, you can just say it's septic, and you will find an explanation to everything that is happening or not happening to the patient. So we humans are rational animals. We try to put a logic to everything, and we do not bother to know that it is correct or not. We just want to feel like we know something or we're doing something without making the effort to actually check whether it is correct or not and what difference it is making, or is it doing any harm. Next we will start with neurology. In neurology I will start with headache because previous I have done. What is headache? It is the fourth most common symptom presenting to the ED. In fact, for women and young people also, headache is the most common cause why they skip school as well as office. And headache can have multiple of causes. If you just Google why am I having headache, there are only two possibilities. Either you will be extremely worried or you will be extremely okay. So don't Google headache. Overall, headaches affect everyone. Not having a headache is a minority. So we need to rapidly identify what headache requires treatment and what will just get better with sleep. So what are the pain sensitive organs, pain sensitive structures in our brain? Apart from brain parenchyma has no pain sensors. So the pain sensitive structures in our brain are meninges, are dura and arachnoid matter. Pia matter is not there because pia is completely stuck to the brain. Okay, so the scalp are scalp layer, dura, meninges, its blood supply, venous sinuses are painful, large arteries are painful, and your muscles, head and neck muscles are painful. In presence of any edema, abscess or meningitis, effusion, the muscles get tight, so it is painful to move the head in meningitis. or any brain infection. We have pain sensitive fibers of our 5th, 9th and 10th cranial nerve are trigeminal, glossopharyngeal and vagus nerve. So what are the pain sensitive structures? We go from above to below. First is our scalp, then our meninges, then our blood vessels, our large veins, arteries and our nerves, 5th, 9th and 10th, plus in the neck muscles, head and neck muscles. So earlier, which we had studied in our second year, that the trigeminal nerve and the vasodilatation, serotonin mediated vasodilatation of the brain causes that pulsatile headache, has been refuted, because vasoconstriction and rebound vasodilation does not cause migraine. It is mostly your trigeminal nerve fibers. Occipital nerve irritation may lead to development of occipital neuralgia in your back of the head, and headaches causing raised ICP will irritate, high or low ICPs will irritate your meninges, causing headache. Because if the ICP is raised, it will compress the meninges. If it is low, it will pull the meninges from the scalp. The headaches are typically classified as primary headaches when there is no underlying cause. Example, migraine, tension and cluster headache. And there are secondary headaches. So headaches is divided into two groups, your primary headache and secondary headache. Primary headache when there is no underlying cause. Example, migraine, tension and cluster. Secondary headache are associated with an underlying cause. So the headache is not the disease in itself. It is a symptom of something much serious, which we need to identify and treat in order to treat the headache. Like a tumor, it is associated with an underlying cause, like a tumor, meningitis, subarachnoid hemorrhage, ICH. Although this distinction is not useful in ED, and we should actually, whenever a patient of headache comes, we should ask leading questions to rule out secondary causes of headache. Most patients with headache have conditions that are painful but benign. So our first step as soon as the patient arrives should be to rule out the red flag signs or signs that indicate that the headache is harboring something much serious. A high risk headache accounts only 4% of the headaches, but it's still important to identify it. Improvement of the patient's headache with treatment does not predict a benign cause of a headache. Even a subarachnoid hemorrhage improves very well with paracetamol. So history, examination and some imaging, preferably a NCCT, rules out most of your headache causes. If you still can't rule it out, you can do a lumbar puncture. A patient's age, patient of more than 50 years of age with new or worsening headache represent a high risk group. So all patients of more than 50 age with new or worsening headache need to be evaluated. The incidence of migraine, cluster and tension headaches, which were your primary headaches, decreases with age, thankfully. So I will have less migraine episode when I get older, hopefully. Raising the likelihood of ominous pathology for older patients. The onset of symptom, age and onset of symptom. If it is a sudden onset and rapidly progressing headache, sudden onset severe headache, aka a thunderclap headache. It requires imaging and further diagnosis. A thunderclap headache is defined by pain that reaches 7 out of 10 in less than a minute.